All right. Well, good afternoon, everybody, or good morning for our folks in the western part of the country. I'm Lindsay Browning. I am your host for today's call, and I am the Director of Medicaid Programming at the National Association of Medicaid Directors. So thrilled to be leading this call today. For those who don't know, the National Association of Medicaid Directors is the independent nonprofit association that represents the 56 state and territorial leaders of the Medicaid program. So today, our featured topic is on the crisis workforce, and we're really thrilled to hear from Dr. Amy Watson at the University of Wisconsin-Madison. But first, I'm sorry, in Milwaukee, other part of the state. But first, we're going to take a quick look at our collaborative, who all's on the call today. So we can go to the next slide. And of particular note, I know we've got 10 state Medicaid programs who have staff who are participating here in this collaborative. So good to be among my people, among the state Medicaid folks, and also be joining with many folks who are thought leaders and experts around this critical work of behavioral health crisis. So wonderful to be part of this conversation today. Just another quick reminder on the next slide. Is that you all can access these learning community resources at talk.crisisnow.com. There's all kinds of great materials on there, as well as information for this learning collaborative, this crisis jam that we have each week. So please check it out, take a look at those resources and share them with your colleagues who are also involved in this work. Today's quote is from Dr. Margie Balfour, Connections Health, and the quote is, there's a lot of talk about different crisis services and programs, but all of the pieces must work together as a system. And I know for me, kind of coming from the Medicaid world, we're having lots of conversations about how we think not just about 988, but the whole continuum of services that Medicaid members might need when they're in crisis or need behavioral health services. So next slide, please. So as I mentioned at the outset, today's featured presentation focuses on the workforce that is going to be needed to underpin this crisis system that we are building and expanding as a country. Really excited to hear from Dr. Amy Watson, who, as I said, is from the University of Wisconsin-Milwaukee. Amy has been heavily involved in the law enforcement and mental health crisis space, as well as on the board of directors of CIT International. So Amy, it's a pleasure to meet you and to hear your expert perspective today. So I'll turn it over to you.
All right, thank you so much. So just to get started, I'm currently the president of the board of directors of CIT International. Really the work that I'm talking about here, though, comes from the other side of my professional life. So I'm not necessarily speaking on behalf of CIT International, although there's a lot of consistency. Can I go to the next slide? All right, so I want to first acknowledge what I'm going to be talking about today isn't just sort of my thinking and my work. I've been working with a number of great colleagues, really focused on the piece of, developing alternatives to having police be the primary and oftentimes only responders to mental and behavioral health crisis. So this started with a piece that Michael Compton, Leah Pope, and I did for psychiatric services, where we really first introduced this idea of the potential of creating a new professional role for a community behavioral health crisis responder. We then actually sort of connected with a larger group of folks that were talking in this area, and we worked on a health affairs blog post that really looked at kind of where there may be issues with simply repurposing existing professionals for this work, given some of the workforce constraints. So there we were working with, in addition to Leah, Michael, and I, Jen Carroll, Talid El-Sabawi, Dan Fichter, and Eric Raffala-Yown. And so next slide, please. So I want to start a little bit talking about the problem, and I know this is a group that's been talking about this for quite some time, but we know that in many communities, law enforcement are the primary responders to behavioral health crisis. So even in communities that have mobile crisis teams, really, police may be the only 24/7 immediate response available. And, there's a lot of reasons that we could list, and I could spend all my time talking about the reasons why this isn't an ideal arrangement. And also just that the negative consequences of this reliance on police is really borne by communities of color as well. And just to talk a little bit about kind of where it can be problematic with police, this is a picture from a newspaper. The caption was, it was two police officers responding to a man who was homeless and likely experiencing mental health crisis. And you see the officers, you have one officer with his arms crossed, the other officer with his hand on his gun. So if you were this man experiencing crisis, you'd have to think about, do I feel safe talking to the officer with his hand on his gun? Do I feel safe talking to the officer who actually, his body language is communicating to me that he's not interested in what I have to say? And certainly there are many CIT officers out there that do a fabulous job and do their best to really provide a response that helps people feel safe. But general police training brings with it sort of a different approach, as well as just the uniform and all of that may represent to people. So that can be problematic. And what we've seen is, to address this, communities are developing a variety of approaches. Many communities are implementing co-responder, and I think I have, if we click to the next slide, it'll bring in a new picture. Fortunately, most co-responder teams don't look like this, but this is one of the dangers that if we stop here with co-responder, we're developing teams that, certainly there are appropriate situations for a co-responder team with a clinician and an officer, but you're always sending a police officer. And unfortunately, in some communities, there seems to be a blurring with the clinician that's working for the police agency starting to look like a police officer instead of a clinician. So if you look at this picture, it's really hard to tell. You have to look pretty hard to figure out who the clinician is and who the officer is. And again, with these teams where you have a clinician writing with an officer, the option is always sending a police officer to these calls. Again, some communities have various different types of options available, and the co-responders used for specific circumstances. But in other communities, this is their primary alternative. And my worry is that we may stop there and not actually move on to do what we're seeing now is communities across the country are trying to develop alternative responses that don't involve law enforcement at all when it's appropriate to send that type of response. And they're, comprised of various different professionals, licensed clinicians, nurses, paramedics, peer specialists. And they're often implemented as pilot programs. And what I want to talk a little bit is that, given the significant behavioral workforce shortages that we have, repurposing some of these professionals to provide these response teams actually could be difficult to do. It'd be difficult to actually scale beyond pilots or just patches of local communities. Next slide, please. So just briefly, we know that there's just significant workforce shortages for various professional groups that provide behavioral health services. I think I read recently, we think we have about 40,000 certified peer specialists across the country. We know that there's some shortages in licensed clinicians. And the other issue is that the behavioral health workforce is overwhelmingly white. And if we wanted to really quickly diversify this workforce, particularly for licensed clinicians, there's significant barriers to rapid entry. To get a master's degree takes a lot of time and a lot of student loan debt. So we have this workforce that may not be responsive to the communities that are really asking for these alternative responses as soon as possible. The other thing that we see is that these existing professional groups may not have the specific training for first response in the community. Simply having a master's in social work and a clinical license doesn't necessarily mean that you're prepared to provide first response in the community to behavioral health crisis. So really thinking about what we need to develop so that we have people that are able to do that. I've also anecdotally talked to many communities where they're having difficulties getting some of their behavioral health providers to feel comfortable actually responding in the community without law enforcement. I did locate a DHSS report on workforce, and they looked at some of the different models being used for crisis services. They looked at crisis lines, mobile crisis. And one of the things that I found interesting is that some of the communities that they looked at had better luck with staff with less education, but more community knowledge. And I think this is a piece that carries into the next slide that I'm going to talk about. So next slide, please. So so Michael, Lee, and I initially, and then with a larger group, started thinking about how it might be useful to take a step back and think about what are the core competencies that a behavioral health crisis responder would need. And kind of building up from that to thinking about then how would we develop that workforce. And some initial steps that we did is we convened panels at 2 conferences. And basically we had a panel, we had law enforcement behavioral health providers, emergency communications, emergency medicine, and peer support specialists and family members that were part of the panel at each conference, one at the CIT conference, one at the LEPH conference. And we walked each panel through a set of behavioral health crisis scenarios. And we presented the initial scenario and asked what skills would your crisis responders need? And then we added pieces of information to escalate some of the risk that might be involved to then see if the skill set changed, to really try to get at what are those core competencies that we need to be able to safely send behavioral health crisis responders out into the community without police. Next slide, please. So from these panels, one of the nice things was that one of the conferences was virtual. So I had the recording, and the CIT conference we also recorded. So I was able to then kind of go through the transcripts of the discussion to really pull out what the themes are of what the core skills would be. And the most important thing that came out in both panels is that a core skill would be to be able to engage with the person in crisis and develop a sense of trust and security. So help that person feel safe engaging. And during that discussion, there was a lot of talk about the value of peer support specialists in doing that type of work. They also talked about understanding what people may be experiencing related to mental health symptoms, stress and trauma, and have skills to de-escalate and exhibit empathy and compassion. We had a number of people talk about that, particularly for the scenario with that was in a home with a mother calling on an adult child, really the importance of being able to engage and support family members if they're present. People talked about the need to be able to assess risk and gather information, and finally also to be able to connect people to services, to be able to make a plan and get people connected. They also discussed the importance of safety skills, and that's something that, in future work, we really want to dig more into, because it was hard to get people to really articulate this from a skill level instead of just saying you might need a police officer. Also talked about the need for a collaborative relationship with law enforcement. So if you have people providing response, they have the ability to ask for assistance from law enforcement when appropriate, or to provide assistance to law enforcement. They also talked about the importance of things starting actually at the 911 call taker level, excuse me. The importance that call takers have the ability to triage, gather information that can be passed on, but also to start that de-escalation process. And really all through this, people talked about the value of lived experience and the value of peer support specialists, but also of other types of lived experience that could be very helpful for this work, particularly if we're really thinking about providing alternative responses to communities of color, and making sure that we have we're able to develop professionals that have familiarity and cultural competence and have the ability to work within the communities that really have been asking for these alternative responses the most. Next slide, please. So our panels weren't necessarily, fully representative, scientific, systematic collections of data. So what we're working on now is really putting together a plan to take a more systematic approach to developing and identifying what these core competencies are and key issues for implementing a community behavioral health crisis responders. And these plan steps that will how long they'll take will depend on the funding that we're able to kind of get to support this. But by convening an expert panel that's kind of broad-based experience, so professional and community stakeholders, to guide work and doing key informant interviews across a variety of range of expertise, and thinking about working with people doing violence interrupter work, doing community health work, just to kind of find out what skill sets they have and how they're able to go out and engage and provide safe responses in the community. We're also planning to do focus groups with professional and community stakeholder groups. So making sure that we get particularly, valuing lived experience. So talking to people that might utilize these services, talking to family members in a variety of different communities to really get that feedback. And then kind of bringing that together and developing a Delphi survey to really get some consensus around those core competencies. And once we're able to do that, of course, there's some longer term plans, but we really feel that we could develop some training, and actually a lot of curriculum already exists out there for pieces of it as we identify what these skill sets are, and eventually lead this to a certification process that reduces barriers to entry into this work. So it could be something where there's multiple pathways where certified peer specialists could gain an extra certification, or where I'm in a college of social work. I think it would be a great certification for bachelor's level social workers. But also I could see a role for community colleges as well. And so really thinking about how do we create access to entry into the field so that we can develop a larger workforce, but also a workforce that really represents the communities that we're trying to serve. And really thinking about the value of lived experience and thinking about it broadly. And I certainly see a role. I know there's some discussion last week about peer support, and this isn't an attempt to change what peer support services are, but I actually could see this at peer support specialists as having an important role in this and having a pathway to this, along with some career progression, similar to like an EMT career progression, so that people have a pathway to higher pay. And again, there's a lot of work to be done to look at implementation models and that can be tailored to local contexts and billing and the like. So I think there's a lot of work to do, but we're hoping that if we can take a step back and first take a look at what those competencies are, that we can start working and build that moving forward. And I really like the idea of having multiple pathways for people to enter this work. I have one more slide, and can we go to the next slide? So something that's come up recently and has been passed around in some of the circles that I'm working in is was a study that came out from the Cynthia Lum and colleagues for the Center for Evidence-Based Policing. And in some policy circles, it's been used to kind of suggest that we don't need to develop alternatives and shift responsibility away from police whenever it's safe to do so, and develop these other resources. And it's a study that looked at 911 calls for services in 9 communities across the country. And they looked at different categories of calls, and they concluded that only 1.3% of police calls for service are mental health related. And so there was also the picture here is they did a Washington Post guest post talking about this and how really thinking about shifting mental health calls away wouldn't greatly affect police workload. And a number of us have, of my research colleagues, have been really kind of upset about how this study is being put forward and how people are interpreting what it means. Because what's well known in people working in this field is that 911 coding protocols really don't allow for accurate counts of behavioral health calls. It's a significant undercount. While we know that oftentimes behavioral health and mental health calls aren't identified at the 911 call taker level, even when they are, other codes may take priority over a mental health indicator. So a lot of calls that would be very appropriate for alternative responders that would be behavioral health, mental health crisis related, end up in other categories. And in this study, it's likely that they ended up in their categories. They included disorder, suspicious, domestic, and interpersonal. And so really, as a representation of their data, I think they really needed to be more careful about stating that 1.3% was really only calls that had a clear indicator in our current ability to capture those in 911 coding systems, and that the number is likely much higher. And that's, as evidenced by data from the CAHOOTS program. There was an analysis by the Eugene Police Department that suggests that they're able to divert 5 to 8% of calls for service from police to the CAHOOTS program. So that's something I just wanted to look at. A couple of us are working on writing a response to this Washington Post thing, just to kind of clarify what we really think the interpretation of the data should be, because otherwise it could actually have some unfortunate policy impacts as well. And so hopefully I stuck to my time well enough. I think there's some time for questions.
Yeah, thank you so much, Amy. That was fabulous, and what incredible research you've done with pulling together those core competencies. One quick question we got in the chat that I've been wondering too is, can you speak to kind of any comparative effectiveness research of the different types of mobile teams, right? Do we know from the research that, BH only or BH plus police or EMT paramedic and peers, like kind of which models get the best outcomes?
Well, that's a really good question. And there isn't really much that's actually put these different models head to head. We certainly know that there's some data on co-responder teams that have a clinician and an officer, that they appear to reduce emergency department runs and do a better job in terms of getting people connected to services than just a police only type of model. Having the clinician there allows for where an officer might not feel comfortable making the determination on whether or not the person needs to go to the hospital. So they're going to take them to someone who can evaluate that. Having the clinician on scene is useful. The clinician also then has some additional resources to connect people to. There hasn't been a ton of research on the mobile crisis teams, at least not comparing, but what I've seen on some of the mobile crisis teams too, is that they're actually able, by going and meeting with people in the community, they're able to prevent some of those ED runs and provide, better connection to care. In terms of comparing things and looking at, the different makeup of teams, there really isn't much out there. And so I think what we have right now is really thinking about trying to gather information from all the different stakeholders to find out, kind of from different perspectives, what do people want when they're in crisis? What can we provide, and work from there, and then we'll need to do some of that comparative research.
It's really helpful. I wanted to ask a question. You mentioned that the workforce is overwhelmingly white and the importance of kind of cultural competence in this workforce. Can you just say a little bit more about what you see as the most important next step to increase the diversity of the workforce, and in particular, if that comment you made about the lack of diversity in the workforce, is that specifically like social workers and those types of folks, or is it peers too? And again, what step can be taken to move us to a more diverse workforce?
I mean, certainly social workers, psychologists, psychiatrists. I have not seen data specifically on the demographics of peers, so I can't really speak with any authority to that. But I do think it's really important that we start looking for, I guess one of the things that I run into, I train master's level social workers, and we're predominantly white middle-class suburban women, myself included. And I worry that if we're relying, if we don't diversify that workforce more, or think of a new workforce, is that if I'm going into a community that I'm not familiar with or comfortable with, I'm going to be asking for police assist much more often. So if we can really develop, local responses with workforces that reflect the community, you're going to have better judgments about when police assistance is needed. But I've talked to so many people in different communities that have just said, our mental health clinicians don't want to go out to the community. So then I think that what that tells me is then we need to develop a different workforce for this specific type of work. And we need to make sure that it really does look like the communities that they're serving as much as possible. And I think, developing the peer workforce is a great way. But there's a lot of peer specialists that may or may not want to work at 2 a.m. on a Saturday morning. So, so thinking about the peer workforce, but also thinking about additional pieces, additional lived experience and training that could be useful for this work.
Great, thank you. And I'm getting the cue that I need to move us on, but there's a healthy conversation going on in the chat. And Amy, hopefully you can feel free to jump in and respond to some of those questions there. But I want to turn to Dr. Eric Rafla-Yan and Dr. Stephanie Woodward, really to offer some reactions and reflections from where they sit. Dr. Rafla-Yan as a congressional fellow and Dr. Stephanie Woodward as a leader from the state of Nevada. So I would love to turn to Eric first, just to offer a couple of quick reflections on what Amy shared.
Thanks, Lindsay, and thanks to Amy. I think this talk is terrific, and I think that the material is so important. From a larger structural perspective, I think one of the reasons why this is so important is that we often rely on police to take care of these types of services because we have no other infrastructure to provide it, and we have no other type of infrastructure to invest in. And so if we have community-based services that we can invest in, I think that would be like an ideal target for policymakers. But if what currently is the only thing that exists is police, then if we want to invest in something, that's what's currently and ready to take those funds. I think another thing that Dr. Watson mentioned that was really important is making sure that there are pathways for folks to be able to work in their own communities, and currently there aren't. On the medical side, as an EMT, so depending on what state you're in, you can get that training in as short as a few months and then be working on an ambulance, and we have nothing like that on the mental health side. Peers are definitely very important, but there are folks who would be really qualified to do this work with a small amount of training who don't necessarily have that type of lived experience that a peer might have. And so this would definitely allow us to expand that workforce pool. And the last thing I wanted to mention, something that has been brought up a little bit in the chat about co-response. There are times when co-responder models are absolutely necessary, when you do want to have police there because it would be unsafe, or it is unsafe really to have anyone there. And so then you want police there. Perhaps a time for that is someone needs to be involuntarily transported to the hospital and that person doesn't want to go. And so however, the times when those units would be needed is likely very small, and is less than 10%, less than 5%, depending on what study or jurisdiction you look at. And so making sure that we dedicate the right resources to the right types of calls, I think is also an important step.
Yeah, and I think that point around co-responder models and different models being needed at different times is important because, as state leaders, you want to provide flexibility for communities to build what's right for them, but also support the evidence-based practice, right? When a certain model makes sense, and how do we ensure that alignment with evidence-based practice? So it's a continual challenge. Stephanie, you come at this from the state perspective. How are you guys thinking about some of these workforce competencies and challenges that were raised?
So I'm actually thrilled to hear that there's some work happening at the national level to identify core competencies. What we know is that when we can distill core competencies down to training, education, and experience, and really understand what the knowledge and the attitudes and the skills are that make up those core competencies, the easier we will be able to identify individuals who either meet those core competencies or can be trained to develop those core competencies. That whole pathway to identifying an individual and helping them move through potentially a career pathway, I think is incredibly exciting. We've had these conversations in Nevada specifically around recognizing that even individuals who are licensed behavioral health professionals are not necessarily equipped with those core competencies to be able to respond as necessary in crisis situations. One of the lessons that we've learned in Nevada is to take some experiences out of disaster behavioral health. So under our crisis counseling assistance and training grant through FEMA and Samsa this past year, we actually developed what we consider a paraprofessional workforce. Some of those individuals do have lived experience. Others have some of the basic experience necessary to eventually become community health workers. But seeing that having a basic training in suicide prevention, safety planning, as well as knowledge of resources in one's community and some psychological first aid really collectively has enabled us to develop this additional workforce that we have seen has had profound impact in helping to respond to some of the needs as they've emerged related to COVID.
It's really helpful to hear. And I think those on the ground examples of, how states are taking on this big challenge of building the workforce is so critical and can support learning across the country. So thank you, Stephanie, for sharing that. I want to keep us moving and turn now to our regular standing updates and items on this call. The first one is I want to hear from Stephanie Hepburn about the most recent crisis talk. So Stephanie?
Yeah. Hi, how are you doing? So this week I chatted with Johnny Gasper. Hopefully he's on the line, and it's, I think it flows very well with this conversation, talking about potential intercept points and when can that happen. A lot of the conversations I've had have talked about, if there are behavioral health crisis responders at the 911 call center, can it work virtually? Because having people co-located, it's difficult to do that at every PSAP. And so Johnny talked about, initially at the Tucson 911 call center, there were behavioral health crisis responders who were actually co-located, and that's the plan. The plan is to go back to that. But during COVID, it created this shift where the crisis responders were taken off the floor and worked virtually. And Johnny and his colleagues were concerned what would happen with this change, the efficacy of being co-located if it's virtual as opposed to physically co-located. And I'm hearing a lot of communities struggle with this very same issue. And what he found, and Johnny, if you're on the call, if you could talk a little bit about some of the surprising benefits of actually during this temporary co-location, what you found in terms of scalability and how it might work actually for remote locations.
Yeah, this is Johnny Gasper. I appreciate that. Thanks, Stephanie. So yeah, what we found in moving, honestly, kind of a diamond in the rough, right? In moving to a virtual co-location during the COVID-19 pandemic, realistically, our co-located crisis professionals had computer-aided dispatch access that required specialty training. So we really wanted to be careful to ensure that, if they were, we were concerned in a setting where they would be with other individuals, that, should they become ill, we would have a hiccup in our program, right? So in moving to virtual co-location, establishing a toll-free number, a dedicated line that connected directly to them and could leverage that CAT access, we actually saw an increase in utilization. Because we had a dedicated line, we could also allocate additional resources from our crisis line that maybe didn't have CAT access, but did have some extensive training with law enforcement to take on more calls. So we saw over 100% increase in that change. Realistically, maybe not as beneficial to build those relationships at the 911 Communications Center, but what we really saw and gained from that was the knowledge that even a virtual co-location in a setting where maybe we couldn't hire, or in a smaller department that wasn't going to transfer us a significant volume of calls, we could still dedicate professionals with law enforcement experience or first responder experience and even CAD access that could then take those calls and leverage it as an opportunity to really intervene from a behavioral health perspective before it came to a face-to-face response by a first responder or crisis mobile team.
Do you mind just expanding what the dedicated line looks like? What does that mean in terms of being able to scale?
Yeah, so our dedicated TFN or toll-free number is skilled or works directly or linked directly to crisis professionals that either have that CAD access or that have more extensive experience on the crisis line. So the calls as a priority go to those individuals rather than the generalized crisis professionals. So that way the people that are calling from 911 really are still talking to the people that were co-located historically at the 911 communications center and had built those relationships, right? We wanted these 911 dispatchers to contact and still connect with the people that maybe were in the office before, but now just happen to be at home, right? In a non-congregate setting. But we still wanted them to feel connected to those individuals, still know that we were there to support them, albeit virtually, but to, again, improve upon that relationship and continue to respond to the best of our ability.
I think one other last point was just talking about rural communities or communities that have fewer resources, and how this model, what you found is that this could feasibly work for more remote communities with fewer resources.
Yeah, so that's definitely what our big takeaway is and kind of how we're looking to expand it now, right? We are partnered with Tucson Police Department in our kind of largest urban setting and Pima County Sheriff's Department for these 911 calls currently, but in dedicating that line and doing this virtually, and again, in building the relationships with other 911 communication centers, there is that opportunity to establish connections virtually. So we don't need to do it in an urban setting where it might be easier to hire or dedicate resources, right? We can build the relationship, have people go out, train, get their CAD access for other communication centers, and then still connect in rural communities with those 911 centers that maybe won't send us a significant volume of calls, but again, is significant to the population that's in the area, right? So even if they're not receiving 10,000 calls a day, it still is important to us when individuals are in a behavioral health crisis to still service that community effectively. So even if it is 10 calls that those first responders in a smaller community aren't going to, that are coming to us as behavioral health professionals, that's a great benefit to the community. And again, from our perspective, ensures that we're servicing the community to the best of our ability.
Thank you, Johnny. Lindsay, do you have any questions?
No, I appreciate you sharing that. I think it's really helpful to hear kind of how you're doing this on the ground and working through some of those issues. So thank you for sharing.
Thank you.
All right. Well, let's move us on to our Samsa update. So I'm going to pitch it to John. John, are you with us?
Yeah, sorry about that. I was on mute for a second. I'm going to actually yield my couple of minutes to Dr. Melinda Baldwin from Samsa because we wanted her to provide a very brief update on some of the exciting work that Samsa has been involved in with respect to youth crisis convenings and recommendations regarding youth crisis design. So Melinda, if you're on the call, could you provide a brief update on what you've been involved with?
Sure, thanks, John. As John said, I'm Melinda Baldwin. I'm the Director of Prevention, Traumatic Stress and Special Programs Division, and that's a huge title for our Children's Division. As many of you know, we've been talking about what's needed in a children's crisis continuum, a continuum that meets the unique developmental needs of children, youth, and young adults in the context of their families and caregivers. Yesterday, we concluded a series of meetings with an expert stakeholder group that included young people and their families with lived experience. Throughout our meetings, we have shared, learned, and dialogued about a lot of information surrounding crisis care for children, youth, and young adults. We discussed our values and the values that we feel are important to undergird a crisis system that serves young people well. Young people are interconnected in their relationships with others, their families, their extended kinship and fictive kin networks. Crisis situations with young people can often significantly impair the parent or caregiver's ability to respond to the crisis and de-escalate the situation. Supporting parents and caregivers in the moment of crisis is an essential component of children's crisis care. We know that children and adults are developmentally different than adults, and people working within the crisis system need to understand these developmental differences and be able to respond accordingly. And then recognizing the disproportionate outcomes associated with policing on historically underserved communities, including our Black and Latinx communities, families facing housing instability or homelessness, and communities with low socioeconomic status. And in the importance of developing a customized trauma-informed crisis response system for children and their families. And lastly, but maybe most importantly, our value of keeping children in their families and working to ensure that a crisis does not lead to placements unnecessarily in child welfare or juvenile justice. So in using and within the three-pronged Samsa framework of someone to call, someone to respond, and a place to go, we focused on identifying important parts of the crisis system that are important and unique to children. And as you know, each of those prongs pose different challenges when we respond to a young person in crisis. So our first task after we concluded these meetings is to develop a document that jurisdictions will be able to use in planning for their crisis response to children. So we look forward to following up with this group as the work unfolds. Thanks so much, John.
Thanks, Melinda. And I know Richard's on the call. Richard, did you want to provide any brief updates as well?
Yeah, I want to make sure that people are aware that earlier this week, Samsa released the 2020 National Survey on Drug Use and Health, which is a rich source of information on numerous issues, including, a very detailed work on substance use and abuse that comes from the household survey. But what I wanted to call people's attention to is the suicide data for 2020 that was released at that time. And this includes, and as the NISDA does on an annual basis, it gave an estimate of suicidal people who seriously were considering suicide. These are adults age 18 and over and non-institutionalized. And the numbers for suicidal ideation in 2020 was 12.2 million. The number who made suicide plans was 3.2 million. And the number who made suicide attempts was 1.2 million. That's age 18 and over. The NISDA also reported this year on youth age 12 to 17, and that is really important as well. For the 12 to 17-year-old group, the NISDA data showed 3 million of seriously considering suicide, 1.3 million making suicide plans, and 629,000 making suicide attempts. So to put that in a little bit of context, if you look at suicide attempts, and this is self-reported suicide attempts, for the adults 18 and over and the 12 to 17 combined, that number comes to over 1.8 million Americans. And of that number, more than a third are age 12 to 17. And I think that this certainly speaks powerfully for the importance of our ongoing emphasis on youth crisis services, as Melinda was just talking about, as well as strengthening our suicide prevention efforts for youth, and of course, across the lifespan, all told. So that was one on there. And you can do a deeper dive into the numbers with what's available on the Samsa website. So that was the main thing I wanted to make people aware of, that is out. It's on the Samsa website, including a PowerPoint going over the key findings and other resources.
Thank you.
So that's all I have.
Thank you, Richard. John, anything else?
No, that's it for Samsa for today. Thank you, Lindsay.
Great. And yeah, I think I saw that the new report come out, and I'll be taking a close look. I think there's some really good data in there. And for folks who didn't know, I'll give a shameless plug. So NAMD's fall conference is coming up around a variety of Medicaid topics, but we have a session focused on crisis, particularly around youth crisis. So it's definitely a topic that's resonating in the Medicaid world too. All right, let's move on to the NASHPIT update. So Brian?
Yeah, thank you, Lindsay, and excellent job. Thank you. The topics so far have been really of great interest, talking about children, youth, and family issues relative to crisis and also workforce. So I'm going to turn it over quickly to Megan to talk about workforce. Megan?
Yeah, thank you, Brian. One of the things that NASHPIT is really emphasizing is workforce. Our states are working very hard to implement 988 and crisis services, and have emphasized, almost every single state have emphasized the struggles they have with workforce. I think the presentation today is just absolutely excellent because it provides solutions. And that is something that has been a real challenge. And some of the strategies that states have used for their workforce are appreciation, the understanding people that are tired and they just need some time off, as well as increased pay, that some strategies there. But this presentation today really honed in on how important it is to rethink the workforce and really be solution focused. And I think some of the strategies that states have come up with, as well as some of the pieces that were presented today, but also help with retention. I think we need to be looking at that. We hear a lot about turnover in crisis workers. And so in addition to rethinking the workforce, I think we also need to think about retention. Thank you.
Thank you, Megan. Back to you, Lindsay.
Awesome. Well, thank you guys so much. All right, next we're going to hear again from Dr. Eric Raflayan about the Herrera-Butler legislation. So Eric?
Yeah, hello again, everyone. I was planning on doing this section with Sarah Corcoran, but so some of you may know me. I have served in the office of U.S. Congressman Tony Cardenas, who represents the northern Los Angeles area and in California. So he and 3 other members of the House have introduced HR 5611, which is an identical companion. The Senate bill, Senate 1902 by Cortez Masto of Nevada and Cornyn from Texas. That one's been out a little bit longer, so you may know it. The Samsa quote of someone to call, someone to come, and somewhere to go. I think Congress has done a good job of the someone to call part, but not the other pieces. And so one of the big things, this bill does a couple of big things. One, which is it really helps codify some of the SAMHSA best guidance, or best practices guidance into the crisis continuum, at least legislatively. And then the other big thing that it does is it really emphasizes that crisis services are a covered entitlement for all insurers. And we think that this would really help support the ability of states to implement these services in a comprehensive way. Because right now, a lot of those states are shouldering it on their own with funding pools that they're taking from other resources, because crisis services hasn't traditionally been something that's been budgeted for.
Great, thank you so much. All right, next I'm going to turn it back to Brian Hepburn for an update on some of the great resources you all can find in the Crisis Now library. So Brian?
Yeah, thank you, Lindsay. And just to bring your attention to crisisnow.com, all these articles that we've put together since 2016 are available. As you remember, we've started focusing on beyond beds in 2016, really focusing on community services and making sure every community had that full continuum. We had a series of, each picture here represents 10 papers. We tried to have a common theme through each of them. And as you go across, all of them address beyond beds. And we started addressing crisis services in 2016, with that 2017 paper. I want to give a shout out to Dr. Deb Pinels. She has been someone who has edited our papers, especially the last compendium of papers. She edited all of them, and she's been a major contributor to many of the papers. But I think you would find, if you look at these papers on the crisisnow.com website, you can find a paper that addresses anything you can think of. It's related to the continuum of care and specifically 988, COVID-19 and crisis services. We think these are really well done, and we want to thank Samsa for working with us on this. So thank you.
Great, thanks, Brian. All right, now we're going to turn it to our relatively new standing item, which is the Crisis Trivia Hot Seat. And Dr. Brian Sims is in the hot seat today, but here's the context for our trivia question. So many of you all may know that Arizona is actually the last state to join the traditional federal Medicaid program in 1982, but they've used the 1115 waiver authority to operate their program and drive some really cool innovation. So they use that 1115 waiver coupled with expanded state plan services and MCO network requirements, as well as braiding both state-only and Samsa funding for the uninsured and underinsured. So that's sort of the context for today's question about Arizona. But the question itself is here. So what funding tool does Access, which is, again, Arizona Medicaid and also their Behavioral Health Authority, do they use to dedicate resources to crisis? So, Dr. Sims, what do you think the answer is? And do you want to phone a friend or ask the audience?
You know what? In interest of time and otherwise, I'm going to default immediately and ask the audience on this one.
And Tom Betlach, you're not able to answer, and I think Dana's not on today. So those folks who know can't jump in, but others, please jump in and share your thoughts in the chat. I'll admit I did not have the right answer to this when we were looking at the question earlier, and I was ashamed since I work in the Medicaid world. Anyone going to help Dr. Sims out?
Yeah, well, Lindsay, I thank you for that answer because it really makes me feel a lot better.
That's a really hard question, Lindsay. It's great to have you on, but that's a really tough question. I'm not sure many people can get this one.
We've got a couple of ideas in the chat, the 1115, the SPA, so the Medicaid authorities, legislatively funded crisis services, a block grant, local money. A couple of ideas there, Dr. Sims.
Wow. And all fantastic ones. How about then we'll go with what the audience is saying, the legislatively funded crisis service.
All right, Karen, can you pull up the answer? So the answer is the crisis capitation rate. Tom, do you want to add anything about that?
Sure. I think Arizona's system has evolved, and it's somewhat unique in that it capitates crisis services specifically to managed care organizations. So oftentimes MCOs, MCOs receive a per member per month capitation to reflect the cost of the population that they're serving. But Arizona is unique in that it capitates specifically crisis services to managed care organizations. It does some of the other things that were recognized here in terms of legislative appropriations to braid funding and leveraging the state plan. But I think what makes Arizona unique is this contractual connection in terms of identifying specific dollar amounts that are targeted to go towards crisis services through the Medicaid program. And Lindsay, it's great to have you on. And Dr. Sims, that was a really tough question. That was a hard one.
Very tough question. And for many of you who are newer to the Medicaid world, you're probably learning that the managed care is a really important piece of how many states operate the Medicaid program. So this Arizona example is really, really interesting to bring forward. So thank you, Dr. Sims, and we'll go ahead and move on to our next segment, which is our federal legislative update. So Sarah, I'm going to turn it to you first.
Okay, great. And thank you so much, Lindsay. So first, very quickly, thank you so much to Dr. Eric Refla-Wine for being on the call today and talking about his boss's leadership, as well as the leadership of Reps Blunt Rochester and Fitzpatrick and Herrera Butler on introducing the House companion to that Behavioral Health Crisis Services Expansion Act, which in the Senate is led by Senators Cortez Masto and Cornyn. In the next couple weeks, and thanks to NAMI's leadership on this, we'll make available a draft template letter if organizations want to show support for the bill. But we're working on that, and we'll be able to probably provide some updates next week for that draft template letter. Also, we've heard rumor that the Senate Finance Committee RFI deadline might be pushed back from November 1st. That is the current deadline for responses. Just keep an eye on the Senate Finance website to see if they do update that, but that's what we've been hearing, that will be pushed back. And then finally, in following up for the conversations last week, the Napolitano-Catco letter to CMS was sent on Tuesday morning. I will drop in the chat that link to the press release that is on the Institution for Mental Diseases Exclusion payment policy for crisis receiving facilities in community-based settings. So I'll drop the link to that letter, and that has been sent. Thank you to all the organizations who reached out and showed support for that.
Great, thank you, Sarah. Any updates from Natalie, Taylor, or Laurel at American Foundation for Suicide Prevention?
No updates on our end. Thank you, Sarah.
All right, fantastic. Well, let's turn now to state legislation and want to hear from Laura, Hannah, or Steph at NAMI on what's happening on the state front.
Yeah, hi, Lindsay. This is Stephanie Pasternak from NAMI. So I'll provide a quick update here. A couple quick hits is Florida. I know I've talked about that they have a study bill coming up on the last few calls, and that bill does officially have a bill number now. It is S478. The study is kind of looking at the existing lifeline infrastructure, identifying gaps, and really funding needs for 988 moving forward. Also, there is a new bill, just got an alert about it this morning in Illinois, Senate Bill 2945. It's a pretty simple bill. It looks like it kind of takes from the NASBID model bill and just sets up the 988 fund. I'm not sure if that's indicative of possibly other efforts that are ongoing to maybe plan for state allocations and appropriations of funding, but we'll be investigating that a little bit more to find out kind of what's behind that bill. And I will be updating our map here and our tracker, get that over to you for next week. And then other than that, just a final quick reminder that NAMI and our partners, we're now hosting monthly calls for state level advocates that are actively engaged in pushing 988 policy forward. We've had one call so far. Our next meeting will be on Monday, November 1st, at 4 p.m. Eastern time. So anyone who's heavily involved at the state level in 988 policy is more than welcome to join that call. And I will actually drop in the chat right now where you can sign up for that. And that's it for me.
Great, thank you, Stephanie. Tom and Paul, do you want to take 30 seconds just to give a quick update on the community forecasting crisis simulator, the calculator?
I know Paul's not able to make the call today, and so I don't have the latest from him in terms of what he wanted to share, Lindsay. So I don't have anything specific other than, CMS continues to push out resources to states in terms of the $15 million planning grants. And we're continuing our work in terms of updating the calculator and some of the modeling assumptions that are underlying that. So more to come on future calls. And it's great to have you on this call. Just a reminder of the importance of Medicaid in terms of financing.
Yep. Thank you, Tom. Okay, we'll move it.
This is Laura. Oh,
yeah.
Sorry. I just wanted to add for the state pieces and thank Steph and NAMI for their great work on the tracking. Just wanted to add for the Florida bill, there is some general funds attached for the other pieces of the component, as well as we just saw come out of Washington in the regulatory process. They passed their bill earlier this year. And so we are seeing they're having a hearing November 10th on the regulatory side for requiring the insurers to get a same day, next day appointment for people who are in crisis. So regulatory work continuing, and so lots of good movement there.
Thank you so much, Laura. All right, moving forward, a couple of final slides here. Just a quick reminder that the cards are out there around a number of states that have legislation enacted, so Washington and Nevada. So encourage you to take a look at those, and more cards are coming soon. And then finally, just a heads up about the next few calls. We have Hannah and Steph sharing NAMI's Reimagine Week of Action on November 3rd, so next week. And then Dr. Madeline Gould talking about the Lifeline evaluation on November 10th. And then November 17th, Ron Bruno will be joining us as the featured talk around the dedicated mental health crisis response model. So be sure to join us. And then, of course, we're giving folks off the week of November 24th for the Thanksgiving holiday. And then finally, last but not least, just a reminder about the Moving America Soul on Suicide, that's available, episode 3. And with that, I know my calendar is pinging and that we've reached 1 o'clock. So thank you to all of our presenters and speakers today. Really incredible to hear about the research around workforce and all of the activity happening at the state and federal level to really strengthen the crisis system. I think we're all seeing in the data and hearing in our communities the importance of this work. So really thrilled to be part of it and to be your host for today. So thank you guys so much. Hope to see you next week, and take care.